Welcome. Good evening and welcome to the Day 2 PI interview for ESOC 2022 on the ESOC TV. My name is Lingxing Li and I am from University of Oxford from the United Kingdom. I'm also the co-chair of the PR committee for ESOC 2022. It's my great pleasure to be joined by Professor Silke Walter from Saarland University in Germany. She's
Hello.
going to be our interviewer for today. Welcome, Silke.
Thank you. Hello.
We're also delighted to have the PIs of two trials with us, both of which presented very exciting results yesterday in our plenary session. So first, welcome to Dr. Marion Randolph-Hoff, who is from Oslo Metropolitan University in Norway. She's also the mastermind behind the paramedic Norwegian acute stroke pre-hospital project, PARANASP. Welcome, Marion.
Thank you.
We also have Professor Rao Nogueira from University of Pittsburgh in the United States and Professor Hu Wei from University of Science and Technology of China. Rao and Wei are the PIs of the ATTENTION trial where they looked at endovascular treatment in vessel artery occlusion. Welcome both.
Thank you.
So I'm going to hand over to Silke for the interview. Over to you, Silke.
Thank you very much, Lingxin. So today we speak about two trials which address the hyperacute treatment of stroke patients. And I would say let's start with the PARANASP trial. Marion, can you tell us a bit more about the aims and the findings of your trial, please?
Yes, I would very much like to do that. In the PARANASP, we aim to create a common language and a standardized pathway for communication from the pre-hospital phase with the ambulance workers, with the paramedics, and throughout the chain into the hospital, and also in hospital, in treatment, and via the stroke ward. And we created a model that is a digital application integrating the competence e-learning and pre-hospital NIHSS, communicating with the physicians at the hospital.
Okay, thank you. And just for all those of us who are not so familiar with the pre-hospital setting, can you explain a bit more what the conventional pathways are? So to understand what the difference in your trial was?
Yeah, I believe that in most countries that we have a quite heterogeneous pre-hospital pathway with different levels of education on the pre-hospital personnel, from emergency medical technicians up to paramedics. Yeah. And also some countries have pre-hospital physicians as well. And what we've seen is that the common language, the standardized clinical approach for stroke patients has been missing. And we believe that a diagnosis like acute stroke with a rapid development of pathophysiology that will happen in the pre-hospital part of the chain of stroke survival will need standardized communication, standardized competence, and a common language throughout the whole chain.
That actually sounds absolutely fantastic. You mentioned this e-stroke model. Yeah. Can you explain us a bit more? What does that mean? What exactly would you want to change with your intervention?
Yes, and I brought a video.
Oh, really? Oh, that's perfect.
Yeah, should we look at that one? Yeah. Yes. What we see is the chain of stroke survival that starts with the dispatch center and dispatching the ambulance. And the paramedics are the first one to do a clinical assessment of the stroke patient, and they will, with the integrated NIHSS, be able to send digitally communication to the stroke physician so that they are ready when the patient arrives at the hospital. And then we hope that our model, the e-stroke model in the PARANASP project, will enable more patient treated, more correct triage to stroke centers, and be the better for the patients.
That sounds absolutely fantastic. Can you explain us, yesterday you reported that you had a much higher number of patients with large strokes in your control group compared to your intervention group. I think the difference was 20.5% of patients who received thrombectomy in the control group and 8.8% of patients with thrombectomy in the intervention group. How can you explain this difference? Yeah. Why did that happen?
I don't know if I can explain it through at the moment because we just finished the analysis, but what we believe maybe can be an explanation is that in the control group they were asked to use the conventional way of assessing patients, which is with FAST and with different approaches, and we know that FAST is quite good to find large vessel occlusion symptoms, but And maybe that's why they also included these patients, because they were asked to include patients that had suspected stroke. But in the intervention study, they used the NIHSS, which we believe and which is validated to find also minor strokes. And maybe that is the reason that we have a higher proportion of minor strokes in the intervention group.
Okay, and this is what you will further analyze now?
Definitely.
All right,
yeah.
okay. So I think many people might ask why there are very many apps you can use to assess NIHSS and to examine your patients. What is different in your e-stroke model? Why can't we just use a normal app from MD Calc, for example, our normal paper forms? Why do you think your model is better?
I think just to assess NIHSS, physicians that are trained in neurology would have a lot of help from a calculator, but in our model we have a communication program so that the NIHSS is translated into pictograms, and it's a calculator, and you also put into vital scores, you put in anticoagulate the drugs use and time of symptom onset, and all this information is directly transferred to the in-hospital stroke physician, and it's visible at the time when the patient is on their way to the hospital, so they can prepare. So that's maybe the main reason why the e-stroke model adds something more into this than just the NIHSS calculator.
Okay, thank you. And what's the feedback from people using this e-stroke model? Can you share this information? Is there any comments of the pre-hospital teams when they use this model compared to standard pathways?
I can tell you that when we stopped the study in July 2021, both the paramedics and the stroke physicians said, no way, we will continue to use the e-stroke model.
That sounds fantastic. Yeah. When can we read your results?
Hopefully we will admit the results this summer. Yeah.
That sounds perfect. Thank you very much, and congratulations again to this really excellent trial. We have Professor Wai Hu today here, and together with Professor Nogueira, they both are the PIs of the ATTENTION trial, as introduced the trial investigating endovascular treatment for patients with basilar artery occlusion. Hello to both of you. Professor Wai Hu, can you give us some details about the trial design and what makes it different compared to the BEST and BASICS trial, which both also addressed exactly this question, endovascular treatment for patients with basilar artery occlusion?
That's a really good question. In fact, we have learned a lot from BEST and BASICS trial. From the BEST trial, we learned that crossovers must be strictly prohibited. At the same time, from the BEST trial, we knew that the sulfectomy is superior to medical therapy only in patients with disease greater than 10. Therefore, we adopted to the randomization ratio between sulfectomy groups and the standard medical therapy group. Such a design is increase the speed of enrollment and also adapt to the current situation. Meanwhile, enrolled only moderate to severe patients. In addition, we kept efficient communication and mentoring with investigators at each center to ensure the consecutive enrollment and prevent crossover. I suggest that these factors explain to a large extent the difference between ATTENTION and the previous BEST and the BASICS trial. Thank you all.
Thank you very much. Raul, can you tell us a bit more about your excellent findings?
So, ATTENTION was completed actually recently. We just finished the analysis a few days prior to our presentation. Essentially, we enrolled 340 patients over a very short course. We started enrolling February last year, and we finished enrollment actually January this year. Then you follow the patients for 90 days for our primary endpoint, which was the modified Rank scale of 0 to 2, defined as the favorable outcome. So what you saw, again, as Professor Hu said, you had a 2-to-1 randomization. So you end up having 246 patients in treatment versus 142 patients in the control. And when you look at the baseline characteristics, age was around 67 for median. The median age stroke scale was around 24. Median PC, posterior circulation aspect score, was 9. Time from last seen well, or actually estimated time of basal artery occlusion, I should say, to randomization was about 5 hours. 1 out of 3 patients receive thrombolytics in general out of place. And we achieve a much higher rate of our primary endpoint of favorable outcomes in the endovascular group. Specifically in the control, best medical management alone, you had a rate of 22.8% versus 46% in the endovascular group.
Yeah, that is fantastic. That is really very great for all our patients.
It's an adjusted risk ratio of 2.1, a number needs to treat of 4. So
that's
really happy about
very brilliant,
results.
very brilliant. Have you done any subgroup analysis of those patients who received IV thrombolysis in addition?
Yes, that was
different. These results.
So essentially, we had pre-specified subgroup analysis. It's always important that any randomized clinical trial, as you know, these things are not powered for. It's more exploratory, right? But the only subgroup that had some treatment effect difference was the PC aspects that actually surprising had a tendency to do better with the PC aspects that were lower, which actually makes us feeling more comfortable that you can treat those patients even if they are a little more affected. Specifically, when you look at intravenous thrombolysis and a total of 108 patients, about a third of the patients got intravenous thrombolysis. There was no treatment effect modification. The adjusted risk ratio was a little lower. It was 1.6 for IVT versus 2.6 for no-IVT, but there was no treatment effect modification.
Okay. Oh, that is interesting to know. So what do we do now with patients with an NIHSS of below 10? That's a question we all would like to know, because that does happen.
that may be the topic of attention too.
All right,
so
great.
Let's see.
We hear the results next year then?
No, I think it's going to be a cohort that it's going to be probably easier to randomize. I think it's a cohort that many more people will have equipoise. The BASICS trial was the only trial to fully really explore that cohort of patients. And you know that in BASICS, there wasn't really a sign of improvement. In fact, those were the patients that likely diluted the treatment effect size and decreased the chances of the trial of achieving a positive outcome, as we all know. So I think very much like in anterior circulation, there are 2 trials in extremity most, and another trial that we are one of the coordinating centers called ENDOLO. We are looking at the low NIH stroke scale in anterior circulation, and in anterior circulation, you say 0 to 5. I think posterior circulation, very reasonable at this point to say 0 to 10, but the question is, sometimes you can have a 0 to 10 with disabling deficits.
Exactly.
And I'm afraid we wouldn't have enough equipoise to randomize those patients anymore. So maybe it's going to be something like 0 to 10 without highly disabling deficits that you're going to have to randomize.
All right, that's interesting. Thank you. So have you now, after knowing your results, have you adjusted your daily clinical practice already? So what do you do in your hospital? What have you told your colleagues to do?
So I'm a vascular and interventional neurologist, so I'm biased towards intervention. I must say that. I've been very happy with my bias over time because we keep expanding the indications. However, I think the big difference now, right? So there are colleagues that have been more conservative and some even nihilists in relation to endovascular treatment of basal artery occlusion. Definitely BASIC and BAST, they brought some additional controversy to the point that they reestablished the equipoise for attention. But in my practice, I kept treating our basal artery occlusion patients. The difference, though, is when I approach the families, right, I approach them a lot more conservatively. I said, listen, there are 2 trials. They were a bit confusing. There were try to explain a little bit of the methodology flaws without getting too many details. But we cannot tell families with conviction, right? Well, you need to do this. I think it benefits patients. I think now, after the great work from our Chinese colleagues and our collaboration, I think you can more,
confidence.
With more confidence, approach families and say, we should be doing this as long as you have moderate to severe stroke severity.
Yeah, thank you very much. And congratulations to both of you for this really fantastic trial and for also performing that with this speed so that we can hear these results already now. Thank you very much. And I hand over to Ling Xin.
Thank you, Siyuka, and very warm congratulations again on delivering such high-quality trials, which I'm sure will have a lot of impact and ultimately benefit our patients with acute stroke. So thank you very much. So in addition to the studies presented in a plenary session, we also have 2 simultaneous publications today in JAMA, both of which focused on some service organizational aspects of delivering acute stroke treatment. So the first one is flying intervention team versus patient into hospital transfer among patients with acute ischemic stroke in non-urban Germany. And the second is some further analysis from RISCAT trial, looking at direct transportation to thrombectomy-capable center versus local stroke center on neurological outcomes in patients with suspected large vessel occlusion stroke in non-urban areas. So please have a read if you are interested. If you have missed any of the plenary sessions, don't worry. Watch out for the newsletter, which we will include the press release where we have a short summary for all the studies presented. They will also be available on the press portal on the conference website. We have also other PR interviews available on the portal too. So I hope you have enjoyed the conference as much as I have so far, and the excitement continues tomorrow. So tomorrow, I don't know if you've had a look at the program, we have another 10 trials presenting a large trial session in the afternoon, so please stay tuned. So lastly, please also follow us on social media too, at ESOC Stroke and #ESOC 2022. So that's all from us, and thank you very much again to Siyuka, Marion, Rao, and Wei for joining us, and I wish you a nice evening and hope you enjoy the rest of the conference. Thank you very much.